the next 20 minutes or so, I would try to focus on certain aspects of liver function tests which probably we wouldn't have thought of, or we generally don't consider as a part of a workup of a patient with a liver dysfunction. Acute liver failure is frequently encountered in critically ill patients, and despite all the advances and the facilities we have at the moment, is still associated with a high mortality. Ideally, as we have online monitoring for several other organ systems, such a monitoring system of liver function is not yet available at the bedside. But the important aspect we need to consider is that the liver function tests in intensive care have to focus on dynamic aspects as well as the static parameters. That means we need to have a look at what's happening at any given point of time at the point of time, rather than having a look at only the static parameters and making a judgment of the liver dysfunction or its recovery. These tests should help us guide the therapeutic dosing as well as to serve as monitoring tools for the liver function. So there are several static and dynamic tests which we are aware of. The static tests are the ones which we routinely use on a day-to-day basis in acutely ill patients, which are basically the serum activities of liver enzymes, the synthetic function of the liver in terms of coagulation factors and albumin, and of course the bilirubin. But what we do not do more often is the dynamic tests which reflect the perfusion-related abnormalities that happen in the liver in a critically ill patient with compromised hemodynamics. And these dynamic tests would be in terms of clearance of substances like indocyanine green, or they would be related to the formation of metabolites like the metabolism of lidocaine to MEGX. And these dynamic tests actually reveal the otherwise hidden hepatocellular dysfunction in the presence of normal static tests of liver function. So if you algorithmize the liver function tests, you have on one half the static tests which we mentioned, which will measure the excretion, the cholestatic function, the hepatocellular integrity, and of course the synthetic function. This would be the enzymes, the bilirubin, the albumin, and the coagulation factors 5 and 7. But the more important aspect which we should be trying to focus on would be the dynamic tests, which will be looking beyond these static tests, and those are the clearance for half-life of indocyanine green, caffeine, and brome sulfoxylane, the elimination capacity for galactose, and of course the metabolite formation with the 14 carbon dioxide exhalation and metabolites in serum. So we'll have a look at some of these dynamic tests in a little bit of greater detail. Before that, we'll have to consider the static tests as a passing mention. Hyperbilirubinemia may be caused by prehepatic pathologies like hemolysis. It could be because of intrahepatic factors or posthepatic occlusion. Despite its limitations and varied aspects of its use, bilirubin is still widely used for clinical routine assessment and also is an integral component of intensive care scoring systems. When it comes to the enzymatic tests, the enzymes may reflect the extent of hepatocellular necrosis as in transaminases or cholestasis. The serum activities of transaminases we know are increased in various liver diseases, whether it's infective, cirrhotic, or malignant or toxic. The serum activities of aminotransferases, however, are of limited prognostic value and do not reflect the extent of liver cell necrosis appropriately. When it comes to alkaline phosphatase and gamma glutamine transferase, they may be useful for follow-up of liver diseases associated with cholestasis, but not for the dynamically varying liver function in somebody whose systemic hemodynamics are already compromised. Synthetic functions of the liver or the hepatocellular synthesis is reflected in albumin and the protein synthesis and the coagulation factors, prothrombin and thromboplastin time. These indicators characterize the extent of loss of functional liver cell mass. A reduced synthesis activity would result in low concentrations, but this is sometimes usually a consequence of the insult, and once the damage has already been done. So we might actually be looking at something that has been past. With progressive liver insufficiency, the serum activity of cholinesterase and albumin will also decrease, but again, this is very varied in a critically ill sick patient, especially in a malnourished society like ours. So that sets the ground for some emphasis we have to lay on dynamic tests of liver function, which might give us an early window or early view of what's happening at the perfusion and synthesis level before those changes of static tests actually come into action. The dynamic tests are related to the ability of the liver to metabolize or eliminate defined substances. And the dynamic tests have the advantage of quantifying the functional status at a time point of assessment and with relatively short turnover time. So that is the advantage of a dynamic test over a static test. And all these dynamic tests have a place in the assessment of liver function, whether it is synthetic or otherwise. They may, however, vary considerably with respect to the different varied functions of the liver and their clinical practicability and the time intensity with which we need to apply these tests. The first of these dynamic tests, which has been rather extensively studied, is the indocyanine green clearance test, which is an infrared, indocyanine green we know is an infrared absorbing and fluorescent agent. It's been in clinical use for close to 50 years now. After intravenous injection, indocyanine green is nearly exclusively eliminated by the liver into the bile and does not undergo enterohepatic recirculation. Physiologically, it appears unconjugated in the bile about 8 minutes after its injection. And for determination of its elimination kinetics, about 0.25 to 0.5 milligrams per kg of indocyanine green as sodium iodine are injected intravenously, and its side effects are very, very minimal. Its removal from the blood depends on hepatic blood flow, the parenchymal cellular function, and biliary excretion, so it gives you a measure of these three parameters of liver function. Elimination of indocyanine green can be expressed as a half time. It can also be expressed as a blood clearance, but more reliably it is expressed as indocyanine green plasma disappearance rate. That is the method by which indocyanine green clearance is measured. For the ICG PDR, the initial concentration at the time 0 is normalized to about 100% concentration, and the disappearance rate is the percentage change of indocyanine green detected over time, that is percentage decrease per minute is what it is expressed as in the PDR terms. The ICG PDR can be measured non-invasively, which is a big advantage of this test, by a transcutaneous measuring system for this kind of radio fluorescent technique. And the results are obtained within 6 to 8 minutes, probably the shortest turnover time for any liver function test which we know from the static list. The normal values of indocyanine green clearance and the ICG PDR are considered to be standardized to be over 700 ml per minute per square meter, and in the PDR range it's about 18% decay per minute for a normal hepatic function. The prognostic value of this test has been proven. There are several subsets of patients in which there is strong evidence for the use of ICG PDR, especially in the post-transplant and abdominal trauma subsets of patients. ICG PDR has been correlated with ICU survival. A good review on this appeared in the chest in 2002. Survivors in this group had a significantly higher ICG PDR, 16.4 versus 6.4% in different subpopulations, which included patients with septic multi-organ failure and respiratory distress syndrome. And mortality could be predicted very reliably in those patients whose ICG PDR was under 8% per minute. So this is a fairly well-validated dynamic test of liver function. Patients with ICG PDR over 16% per minute will have no higher mortality than those who have a clearance of about 24% per minute. It is important to note that ICG PDR as a single parameter is comparable to other prognostic systems like Apache 2 and STAPS 2 parameters, which we routinely do. And it is superior to bilirubin in terms of outcome prediction, and it does indicate liver dysfunction much earlier than the static test too. In patients with septic shock, a failure to increase the ICG PDR within within 120 hours to over 5% per minute is associated with poor outcome. This is also fairly well validated study. The transamination bilirubin were less sensitive when compared to ICG PDR, and in a more recent study, in contrast to global hemodynamics, like venous oxygen saturation, ICG-PDR will differentiate survivors from non-survivors among patients who have been resuscitated in emergency rooms as a consequence of septic shock. And it therefore allows early and sensitive detection of liver dysfunction, which might be helpful in clinical management and guiding fluid therapy in patients with ARDS with or without cardiogenic pulmonary edema. And needless to say, it has a role in prognostication prior to liver surgery and for pre-transplant assessment. That's about the indocyanine green test. The next elimination test which we can have a look at is the caffeine test, which caffeine is physiologically metabolized to several metabolites in the liver. The metabolites to caffeine ratio calculated from the blood samples after 4, 8 and 12 hours after a 300 milligram caffeine oral load has been suggested as a good evaluating test for hepatic dysfunction. Elimination of caffeine takes significantly longer in patients whose livers are cirrhotic than in healthy volunteers and with consequent higher half-lives. But such data, as we saw in the ICG-PDR test, are lacking in critically ill patients, and this test requires complex laboratory equipment like HPLC, therefore is not of much clinical relevance at this point of time. The other clearance test we can have a look at is the bromsulfophthalene clearance test, which when injected intravenously is extracted fairly rapidly and exclusively by the liver, and most commonly about 5 milligrams per kg of bromsulfophthalene is administered, and serum determinations are made at half an hour and 45 minutes. In healthy volunteers, less than 10% of this load is retained after half an hour and less than 5% after 45 minutes. This clearance test is superior to the laboratory test for assessment of hepatic functional reserve, but the ICG retention rate at 15 minutes is probably better than the bromsulfophthalene clearance test. This has been studied in pre-transplant assessment. This test, which may be associated with severe systemic reactions which could be fatal and require special laboratory equipment, has been largely abandoned in general clinical use. Amino acid clearance. This clearance test relies on the ability of the liver to eliminate amino acids from the blood. In principle, patients who were fasted overnight received a standardized continuous intravenous amino acid infusion for about 18 hours. After the end of infusion, amino acid concentrations in the plasma are measured and plasma amino acid clearance is calculated. And this is a very time consuming test, and it take 18 hours to conduct the test, so obviously not of relevance in intensive care practice. Galactose elimination capacity. Galactose is phosphorylated by ATP to galactose 1-phosphate before undergoing further metabolism. By plotting the galactose serum concentrations over time to the end of infusion, the linear part of the curve beginning about 15 to 20 minutes is used to extrapolate the time when the concentration was 0, something similar to the ICG-PDR. The galactose elimination capacity is then calculated using the decay of this concentration curve, and the results are expressed in milligrams per kilogram per minute, and it has been found to be reduced in hepatitis and cirrhosis, but not those who have obstruction, but not significantly studied in a pure critical care population. It is limited in its use because it is potentially dangerous because of galactose intolerance and is too cumbersome for application among ICU patients. But the more reliable one seems to be the MEGEX test, the monoethyl glycine xylidide test, which is based on the hepatic conversion of lidocaine to MEGX, which is related to cytochrome P450 system by sequential dealkylation. It is dependent on the hepatic metabolic capacity and hepatic blood flow, and blood samples for determination of MEGEX prior to and 15 minutes after its intravenous injection of lidocaine 1 milligram per kg have been suggested, but its quantification requires again HPLC. It's been used in a variety of intensive care scenarios, including hepatic failure and septic shock. In contrast to the ICG-PDR, the MEGEX test does not allow bedside assessment of liver function. And since it is related to the metabolism of lidocaine, interactions with substances or drugs that result from cytochrome systems have to be considered. And it is not shown to be equivalent to the ICG-PDR test. It is a clinically useful instrument though for assessing liver function, but is limited by the need for the laboratory equipment and potential influence by factors that may be present in critically ill patients. So to conclude, there is no evidence-based guidance for when to assess liver function in critically ill patients by dynamic tests and which therapeutic strategies to be used. Real-time monitoring function at the moment is not being applied for critically ill patients, although there is a pressing need for such a test. In general, results of different tests may vary considerably since they assess different hepatic functions, which per se make a comparison difficult. Both ICG-PDR and the MEGEX tests are clinically most valuable techniques, but the ICG-PDR per se has the advantage of being measured non-invasively at the bedside and providing nearly instantaneous results from an intensive care point of view. So, thank you for your attention.